with the Western Psychiatric Institute and Clinic, which is part of the University of Pittsburgh Medical Center. And I'm very thankful to have with me Dr. Catherine Lehman. She's a psychologist at our center, as well as Jody Tuscolani. She's our program manager for our school-age summer therapeutic inclusion program, and Alan Gregory, who's our program director for the adult autism and vocational programs at Western Psychiatric. So we're going to tackle this fairly large topic of assessing and managing suicidality in autism spectrum disorder. Our learning objectives, I'm going to talk a little bit about identifying risk factors for suicide in youth with autism spectrum disorder. Dr. Lehman's going to carry that on and explain how and what to ask when assessing for suicidality. And then Jody and Alan are going to share about formulating a basic long-term management plan for youth with suicidal ideation. So in general, there's a lot of risk factors for suicidality in youth, and these are drawn from the neurotypical population. Things like age, gender, and ethnicity, with some who might be more familiar with this, such as older white males or people of ethnic minority backgrounds are at higher risk. Certainly if there's a family history of suicide, as well as a current family dysfunction. The social isolation and bullying, as well as any kind of stressful life event, can be a risk factor for suicidal thoughts and behaviors, as well as abuse and trauma or anxiety and depression. One of the big risk factors that I'll mention a little bit more is substance abuse. Certainly when people's inhibitions are lowered after the use of substances, they're more likely to have suicidal thoughts and impulses and to act on them. But also history of attempting suicide or even non-suicidal self-harm is considered a risk factor for suicidal ideation and behaviors. Hopelessness and then access to means. And I highlighted there firearms because when we talk about suicidality, I'm talking not just about attempts but also thoughts and impulses. So firearms in particular are considered a risk because it's a very lethal means for somebody who has an impulsive thought to hurt themselves. It's a lot easier to recover from, say, an overdose and seek help than it is when somebody grabs a firearm to try to hurt themselves. Now we're going to focus specifically today on people with autism spectrum disorders, and for many of you this is probably very familiar information, but for those who don't know, autism is diagnosed in people who struggle in two basic functional domains, one being social interaction and communication, and that can be anywhere from stereotyped communication or a complete lack of any kind of verbal skills at all. And also those who have restricted, repetitive, stereotyped behaviors and activities, so interested in only one fairly arcane topic or repetitive behaviors like flapping or spinning. And in order to qualify for a diagnosis of autism spectrum disorder, these symptoms have to cause a clinically significant impairment in multiple domains of functioning, either on the job or at school, social or other important areas of functioning. Now it used to be thought that people who had developmental disorders, whether it be intellectual disability or autism, couldn't become suicidal. They didn't have the capacity to think about it or to understand it. But I think that thought has been replaced. And I think this quote from the American Association of Suicidology really highlights how this population, if anything, has a higher risk. So the group talked about an intense desire for death that comes from a belief that one is a burden to others or belief that one does not belong. In addition, a sense that one has no liability or is not fulfilling the expectations or obligations, and sometimes can lead to thinking that a person's own death is more valuable than their life. So certainly people who have developmental disabilities have a lot of exposure to these beliefs, and if so, you would think would be even higher risk. So people begin to look at this, and I want to share this study in particular. It's one that was done here in Pittsburgh, and it asked the question, in a developmental disability clinic, as well as the inpatient unit, how common is suicidality? So Antonio Hardin and colleagues looked over 200 patient charts, both from the clinic as well as from the hospital, and did a thorough chart review. And what they saw in those charts is that 20% of these patients had had suicidal ideation or attempts. That's 1 out of 5, which I thought was particularly high, especially when you consider you're also looking at an outpatient setting where usually people are more stable. But what was particularly impressive to me was that there's no history of drug or alcohol abuse, which is not uncommon in this population. Often there's not much substance abuse, but even without that very significant risk factor, there were still a lot of patients who had thought about had suicidal thoughts, thought about hurting themselves. Over half of them had an associated acute psychosocial stressor, and that's a theme that will come up repeatedly in the literature. And even more concerning, over half of these folks had a specific plan, and they were pretty concerning plans: cutting their wrists, stabbing themselves. Then a group in Japan, headed by Mikami, took a kind of opposite way of approaching the same question. And they looked at people admitted to a psychiatric hospital in Japan after a suicide attempt. And from that perspective, looked to see who might have autism. So they did a record review of 94 youth who were admitted following a suicide attempt. And this was a sequential accumulation of patients, not a controlled study, but looking to see what they found. And then they diagnosed autism in 12 out of those 94 patients. So it's about 13%, which if you think about the general prevalence of autism, it's much higher than you would have expected. One of the stressors that usually precipitated the attempt was bullying. It happened in 9 out of these 12 patients. And interestingly, the rate of mood or anxiety disorders for these patients was actually lower in the group who had autism, which is very counterintuitive. You would think depression or anxiety would be just as high as it would in the neurotypical population. So to try to explain that discrepancy, they postulated that perhaps the restricted pattern of thinking that people with autism typically have, or a lack of imagination, so that when they were stressed by the bullying or their other life factors, they couldn't think of any other way out. They didn't think anything would ever change, thus pushing them to feel more desperate and more likely to end their lives. So stepping back a little bit, just to look at the general research literature, what does it tell us about suicidality and autism? In 2013, there was a systematic review done. And unfortunately, looking through the entire literature they could find at the time, only 4 papers explicitly examined suicidality in youth with autism. And from those papers, the prevalence rate was pretty broad, anywhere from 7 to 42%. But they assessed there were some risk factors they actually found to be unique to the population that has autism. When you're looking at autistic population, those who did not have intellectual disability, which is what ID stands for, and intellectual disability is the new DSM-5 term for the old phrase of mental retardation. People with autism who did not have that were more likely to experience a broader range of risk factors and low self-worth. So in essence, they were less likely to be in a protected environment. They also, people with autism, have more of a lack of emotional awareness, so may not realize how bad they're feeling until suddenly it's overwhelming, as well as poor problem-solving skills, so try to figure out other ways to deal with their feelings other than taking their lives. In addition, they also have difficulty with perspective taking, which is unique to autism and one of the core features. So they would have difficulty imagining the impact of their death on others. So certainly when you do a suicide assessment, you ask people, what keeps you from hurting yourself? And often you'll hear, I don't know what would happen to my mom, how that would affect my brother, my sister. So people who can't understand the impact of their death on others are more likely to take that step. And then they also talked about just some of the difficulties in the literature that hopefully at some point we'll be able to solve. But one of them is that a lot of people with autism have non-suicidal self-injury. And certainly if you've worked in the population, those who have the least amount of ability to communicate, those who have intellectual disability, unfortunately are more likely to injure themselves as either out of frustration or as a way to get attention, to let people know that they're in distress and they're seeking out help. So for that reason, it's very difficult in the literature to assess how much of the self-injury may have been due to a suicide attempt versus those other reasons. But also, on the flip side of that, because self-injury is so common, many times the behaviors of self-injury could be attributed to autism instead of an additional disorder such as depression or psychosis that might be causing suicidal ideation. So that problem of diagnostic overshadowing is hard to suss out. So a more direct study, Mays in 2013, did a survey of about 800 youth who had autism. And they asked their parents a series of different questions about how much suicidal ideation or attempts were a problem for their child. And almost 14% rated suicidality as being a problem. In addition, over half of their children were teased or bullied. And when you looked at those youth in particular, the suicidal ideation attempts were 3 times more frequent in those children. The direct predictors of suicidal ideation were primarily depression for people who were thinking about suicide, but for people who attempted, mood dysregulation, so going from one extreme to the other, and with that likely impulsivity. In addition, they carry the same demographic factors that neurotypical population would, such as being of minority ethnicity. In addition, those older than 10 years old, which is probably more likely associated with the ability to have access to a means for suicide, and also more social stressors as they got older and interacted with other kids. So a more recent review by Richa in 2014, they looked at patients with autism who had attempted suicide and found general patterns that the sample suggested that suicide was more frequently in high-functioning autism, and again, probably more likely to be exposed to more of the stressors. So I want to point out in the Mays study, they didn't see that association with autism severity or intellectual disability. So this is something that's probably should be taken with a grain of salt and certainly shouldn't lead anyone to dismiss the possibility of suicidal thoughts and behaviors in lower functioning folks. In addition, the typical things you would expect, those who are physically or sexually abused, bullying, but also changes in routine can be precipitating events associated with suicide risk. So even something that doesn't seem to be that big of a deal, if it's a change in routine of changing schools, moving to a new home, that could be a stressor enough that might lead to suicidal thoughts. So in 2001, the National Longitudinal Transition Study of Special Education Services was done for the U.S. Department of Education. They sent surveys out to over 1,000 different families and looked at specifically 920 youth in special education. And they surveyed both the parents as well as the school principals and the staff. And they looked specifically at bullying. I wanted to spend a little bit of time on this risk factor because it's one that comes up so very often in the literature, but also in the clinic. And I've seen myself many patients where bullying was the main reason that depression worsened and people tried to hurt themselves. So looking at the study, just to see how common bullying is, the prevalence was 46% for youth with autism, and that's over 4 times as high in the general population. So in my clinic, when I'm seeing patients, I ask about school. I'll always ask about bullying because it's so much more common in our population. In addition, kids who are bullied were more likely to have ADHD, lower social skills, but often some form of conversational ability and more time in general education classes, likely placing them around others who may or may not be tolerant of their lower social skills or their hyperactive impulsive behaviors. In 2012, a similar survey was done of nearly 200 youth with autism. And here they asked about frequency, severity from the parents. And over 3/4 of the parents said their child had been bullied at school within the past month. And 1/3 of those, it happened at least twice a week, which is startlingly high in my mind. In addition, over half of them had been bullied for over a year. So these kids were constantly going to a place where they were being bullied and made fun of constantly. Those children who were bullied compared to those who were not were 11 times more likely to have internalizing mental health problems, and that would be things like depression, anxiety, so much higher risk. So speaking of depression, I wanted to spend a little bit of time on that risk factor as well. So looking through the literature by Howland and Gazudin earlier in the 2000s, that people with autism are more likely to have psychiatric disorders, particularly depression. So this is something that comes up repeatedly. Often, however, the studies are based more on verbal individuals because they're easier to do the research on, most likely. And again, more likely in adolescents and adults, probably because they're less protected and there are more demands as these children get older. Leifer in 2006 did direct interviews with parents, and they looked at school-aged and teenage kids. Again, looking at verbal kids who had in the at least average range IQ. And major depression was found in 10% of them, but if you just looked at less intense symptoms or shorter duration, subsyndromal depression, it went up to almost 1 out of 4. So for those who aren't familiar with depression, these are the DSM-5 criteria, and cardinal to that would be depressed mood, as well as anhedonia and loss of pleasure. And then you can see the different domains that it affects as well. Biological functions such as appetite or weight, sleep changes, and people will describe either sleeping more or sleeping a lot less or having difficulty falling asleep. They can also be more restless or feel more slowed down, like kind of leaden leg paralysis is a term that gets used, or feeling like I'm moving through molasses. And with that, loss of energy, and then the cognitive problems of feeling really guilty, feeling worthless, not being able to concentrate, make decisions, and then of course thoughts about either passive death wish, just wishing I was dead, or an active suicidality of I'm going to take my life. Now the complication comes up when we look at autism. There's a lot of overlap between these two disorders. In autism, it's very typical for kids to have social avoidance or not really interact or engage with others. So how do you separate that from social withdrawal? And then at baseline, they often have unusual eating or sleeping habits. So trying to pick out a change from something that's already a chaotic pattern is typical. And then low energy, people who just aren't as engaged with others, is common in autism. And in this particular factors, the flat affects, where they don't show emotions in their facial expressions, and as well as alexithymia, the difficulty even labeling, describing their internal emotional responses, so putting feelings into words. And I wanted to highlight those last two because I think that's something we see clinically that doesn't seem to correlate with severity of autism or intellectual disability. I certainly have many very bright people in my clinic who don't show in their face if they're distressed. They look the same as they did when they were feeling well. And even though they have good communication skills and cognitive abilities, they can't describe other than, I don't feel right, something's wrong, something's bad. So it can be very difficult to identify the depression and thus the suicidal ideation. So I'm going to introduce now Dr. Catherine Lehman, who's going to talk more in detail about how and what to ask when assessing youth with developmental disabilities for suicidality. And then we'll have time for questions more at the end as well.
Okay, thank you, Jessica. So, switch slides there. Okay, so, when we're assessing for suicidality, there's typically a few things that we're looking at. We're looking at ideation, plan, intent, means, access to those means, and then also past attempts are some of the main things that we tend to look for. But those things can be much more difficult to assess in our population. And there are currently no specific assessment measures to screen for suicide in individuals with developmental disabilities. There is one being created in Canada right now as part of a study with NIMH, yeah. But I don't have any of the details on it yet. I don't know what it's going to look like. There are a ton out there. Beck has one, Firestone, Hamilton, Linehan. There's a lot, but they're not specific to people on the autism spectrum, and it can be quite difficult to assess in our population. So we're going to talk a little bit about how to do that. So the basic problems with the existing measures that are out there are reading comprehension levels. So if you try to give them something to complete and fill out, the reading comprehension can be a big issue. Now, if you try to do an interview or read the measure that you want them to use, then the receptive language skills can become an issue. So that can be a difficulty too. The complex response format can be another difficulty. If you give them something like a Likert scale, it's very difficult for our population to fill out a Likert scale because of their kind of black and white, all or nothing thinking. Everything ends up being either a 0 or a 4, and there's very little time where there's any kind of report in between. And the need for abstract thinking. A lot of the measures ask questions about what would you do in this sort of situation, how would you feel if, and those questions can be extremely difficult for our population to answer because of how abstract they are and the open-endedness of the question. So basically what we're looking at is looking at more of the behavioral equivalent activities. So these are things that people do because they're not willing or able to say what they're feeling. So they're basically, behavioral equivalents are what someone does that means depression to them. So in terms of depression, we're looking at, so we'll go through some of the symptoms of depression. So worthlessness, those things could be destroying treasured items, punishing oneself. If we're looking at decreased concentration, that could be failing grades, schoolwork performance declining, poor memory, need additional prompts to complete tasks where they didn't before. Suicidal thoughts would be, focusing on people who have died in the past, self-harm, those types of things. In terms of the depressed irritable symptoms, we're looking at decreased smiling, lack of emotional expression, increased whining, spontaneous crying. Change in sleep and eating are pretty straightforward, although they can also be difficult in our population because a lot of our kids, as Dr. Kettle had mentioned, have difficulty with both of those things in general. So a lot of our kids don't get much sleep, and they can be very selective eaters. So it can be difficult to assess those things as well. Anhedonia, you're looking at things like less responsiveness to preferred activities and passions, increased amount of time spent alone, which again a lot of our kids do always, so that can be a little bit difficult to assess as well. Activity level changing is another big one. So if they're suddenly really lethargic, slow moving, or pacing and they seem like they can't stop moving, that can be a red flag for us too. But really what we're looking at is, this is really the key, is movement away from baseline. You really have to know the kid's baseline, because as we went through all of these examples, it's pretty clear that a lot of our kids, like I said, have difficulty with sleeping, have difficulty with feeding, do isolate to begin with. So understanding where they are normally is really key to understanding if there's a change that needs to be a level of concern, at a level of concern. And I always think of our coworkers here in the office whenever I talk about movement away from baseline, because we have one coworker that I love downstairs who dances her way into the office every morning. She quite literally snaps and dances the whole way down the street from the parking lot to our office. And then we have other coworkers who are, I don't talk to me until I've had my coffee. So if we're looking at the dancer, whose name is Crystal, versus some of the other coworkers, if Crystal came in looking one day like some of our other coworkers who are the don't talk to me until I've had my coffee, I would be much more concerned than I would, with their normal presentation. So you really have to know what people look like on the day-to-day baseline so that you can start to recognize if there's a change in their behavior. So basically you have to know your clients very well so that you know what's going on with them. And so you can assess for, you're looking at the behavioral equivalents of depression, you're looking at risk factors, and you're looking at protective factors. Dr. Kettle went over a lot of the risk factors. Protective factors for us a lot of times are having close and supportive family members, activities that they enjoy doing, even if they are perseverations, they still are things that they love. Having pets, that's a big one. Having a responsibility for a pet often is something that is a big protective factor for our families and our kids. Religion is also an interesting one that is really big for a lot of our kids, because they're such black and white thinkers that if they have a set of religious rules that they're supposed to follow, or they will, for example, go to hell, they take that quite literally. And so religion can be a big protective factor for a lot of our kiddos. Having future goals, future plans, and having coping skills that they're pretty good about using and implementing. Those are all protective factors. So what do we ask? So you have to be very direct with our population, more so I think than other populations. I looked this morning, I was looking over the Beck assessment, and the first question says, have you ever thought about hurting yourself? That is not something that you're going to necessarily get the answer you're looking for you ask a person on the autism spectrum, you have to be direct, and you can't be scared to say, have you thought about killing yourself? Because to them, hurting yourself does not mean killing yourself, because they're different words. Have you tried to kill yourself? What were you doing at that time? Have you made a plan? How would you do it? Do you have access to whatever that, the means might be? And do you think you might go through with it? You have to be direct in how you ask the questions. You want to avoid being judgmental. You wouldn't do this, would you? Or, kind of diminishing their feelings. It's really not that bad. You might be overreacting. Those are the kinds of things that you never want to say. So there are a few tricky things that come up in people on the autism spectrum, and these are difficult questions to answer. So it makes me nervous to try to go through these topics, but I'm going to. There are kids out there who every time they're mad, they go to, I'm going to kill myself, or I'm going to kill someone else. And that's partially because they have difficulty with that gradation of emotion. They go from 0 to 100 very quickly. And they have difficulty feeling more than one feeling at a time. So if they're angry, they're all in on the angry. This is where it's important. You have to know their baseline. You have to know what they look like. If this is something that they do every time they're mad, you have to also understand their intent. Where are they in those types of situations? Is it escape related? Is it frustration related? And then helping them to label their feelings, because our kids have a really difficult time with that. And so they might just need the words to say, I'm frustrated, I'm sad, and they don't know how to express that in any other way than to make this broad statement that they know is going to get the attention of the people around them. And you also do have to consider their means. We have a fair number of kids who will say they're going to hold their breath until they die, or stab themselves with a pencil, or use a laser. And so while we want to take that seriously because they're obviously in distress, those are things that we aren't going to consider to be lethal. So we're looking at when we have nonverbal students really, or individuals in general, really regression in functional level. If they're people who shower fairly regularly and take care of themselves, we want to note if they're not doing those things anymore, if they stop taking care of themselves. We want to look at the outward behaviors and see if they're different, if they're becoming aggressive or yelling much more often than they typically do. And then stereotypic and repetitive behaviors also tend to increase whenever people are agitated. So those kinds of things are all things to look for, because they're signs that something's not right, something's different than their baseline. And then we also have a fair number of people who are nonverbal who engage in self-injurious behavior. And that can be difficult to piece apart too and figure out what's going on. So an FBA is really important in those situations to figure out, is it escape, is it avoidance, is it suicidal behavior, or are they doing it because they like the sensation of whatever it is that they're doing. Sometimes kids like the sensation of banging, the vibration on the wall, so they'll bang their head or whatnot. Is there a medical reason? We have a lot of kids who, when they have dental problems, they might have cavities and their teeth are hurting and they can't tell anyone, so they'll start banging their heads more, or they get chronic headaches. So there could be medical reasons there. Also attention seeking, if you have a child who's banging their head on the floor, the parent's immediate reaction is going to be to go to them, so they know that that's a way to get attention. So although those self-injurious behaviors can be a sign of suicidal behavior, they might be trying to express that they're frustrated. There are a lot of reasons for those self-injurious behaviors, and so an FBA is really the way to go to try to get to the bottom of what's going on there. And so now I'm going to let Jody start talking about formulating a basic long-term management plan.
Hi, good afternoon. Catherine just talked about some of the lower functioning children that we might see, and I am going to take a look at the high functioning autism and what should be considered long-term. But just to mention some of the things that we could use in addition to the functional behavior assessment is to teach those kids to use the picture exchange or PECS cards to label their emotions. They have the assistive technology, so they could use the voice boxes or the iPad to help them communicate. So those are definitely some of the things that can be used with them. But I'm going to start with the higher functioning kiddos. So as was mentioned in the past, the deficits that kids with autism have can make the world a very stressful place for them. The deficits that are probably most significant is the social-emotional reciprocity. As Dr. Kettle mentioned, if they can't express their emotions, then it's really difficult for a therapist to gauge if they have suicidal ideation. Developing and maintaining relationships. This is a big problem with them as they get older, and it can challenge these kids with making friendships and bullying. Theory of mind is another area that we try to address. Perspective taking is huge. They can't understand what somebody else is thinking, as was mentioned. They think whatever they're thinking is the correct way. They're very rigid, and this can lead to behavior problems, tantruming, misconceptions of who's a bully versus who's not a bully, and then it trickles down into anxiety, which they already have, which becomes worse. They have the poor coping skills where they hurt themselves, they hurt someone else, they run, they may wander off, and it's very important to work towards these skills early. And of course, impulse control is a difficult thing, and that should be started really early when the children are little. So what we want to do is we want to teach skills to extinguish these maladaptive behaviors, and that can start early with applied behavior analysis, outpatient therapy, one-to-one therapy, family therapy, and medication management as well. Another thing that we can do with the higher functioning kiddos is that we want to encourage them to have self-advocacy. One of the ways that that can be done, and it's not listed on here, is to teach the kids about their autism. Many children don't even know they have autism. Parents are a little hesitant about mentioning it. So the sooner that can happen, the better. And you want to help them identify their own strengths and weaknesses, particularly the weaknesses, so that they know what they need to overcome. You want to involve the youth as early as possible when they're 14 and they have to do their transition plan to participate in their IEP. This is going to benefit them to understand they can make choices, their opinion is valued, and it helps them to start to set their plan. Youth also have got to be taught how to recognize and deal with bullying. So with self-advocacy, they can ask for help, they can stand up to someone, they are going to have that much more self-confidence and be able to know what to do and how to walk away. They want to encourage them to self-assess a situation. Problem solving is very big area that we work on with the kids at school age. This is in order to make them more independent and also to not enable them and have them depend on somebody else. And as the quote says down here, unfortunately, many young adults on the spectrum are first forced to learn the realities of self-advocacy after high school. The ramifications for not being able to self-advocate or deal with their problems can be very debilitating when they have that jump in to the adult population. Another area that should be focused on is resiliency. We all know what resiliency is. It is something that brings optimism and hope for someone. It shows someone that they can do it. They can come out of whatever is bothering them, frustrating them, making them depressed. And some of the interventions such as ABA and therapy can help them move in that direction. Strategies that can help the youth become more resilient is to start early with low-risk challenges to practice flexible thinking since they are so rigid. This can be done with games. This can be done with challenging their opinions. You can do it with another peer. That helps a lot. They need to develop their self-control strategies by using different techniques such as visual thermometers or talking about their emotions and being to identify how they feel within their body. Also, you want to talk to them about self-talk in order to calm themselves, and us as clinicians and family members are perfect to model those techniques. Parents also need to start looking at the plans for puberty, because when the kids get into that that age group, that is when they become very dramatic. Self-esteem can plummet based on friendships that they might have had before and now they don't. Personal hygiene, their appearance, not knowing how to talk to girls or guys. So a social skills group and is very important for them to be involved in order to address all these different types of deficits. And then, of course, the bullying prevention skills is also important. As Dr. Kettle mentioned, that they are 3 times higher to be teased and to have ideation for suicidality. So as my last slide, these prevention techniques are very important along with self-advocacy, resiliency, in order to transition into young adult. Without these, the transition process can prove to be pretty traumatic for these guys, and they don't know where they're going to head. So now I'm going to give it to Alan Gregory, and he's going to go into the transition piece.
Thank you, Jody. Hi, everyone. Thanks for having us today. Okay. We had some debate here about the transition planning piece being a part of talking about suicide with young people on the spectrum. And we really, when we were looking at the literature, we found that it is a significant part of the landscape, if you will. It is fraught with anxiety for everyone, and because it really encompasses every facet of an individual's life. When we're talking about transition planning, we're really talking not just about finding employment or jobs or volunteering opportunities for folks. We're also talking about what's housing going to look like. Where will I be living? We're talking about perhaps an educational component. Will I be going to school? Will I not be going to school? If I'm not going to school, will I be going to a vocational setting of some sort? There's also a social component and relationship planning that occurs during this period of life, and also for the rest of our lives. There's also the idea of how do I access services once I'm out of school. And this is something that it's continuous. It has to be coordinated, and literally it's something that involves a lifelong journey, if you will. And so with that in mind, what makes sense on an individual basis is to develop a transition plan that includes all of those components that I was just describing. What are vocational training or job sampling, or how do I prepare to be job ready, if you will? What does that look like? Having employment goals and a timeline for achieving what those would, accomplish. Goals in support of what residential opportunities, including independent living, what that's going to become. Community participation, including those social and leisure skills. Travel training. How do I do purchasing? Personal care, accessing my doctor, if you will, just to name a few. Goals relevant to secondary, post-secondary education, college if I'm going to go to college. And then coordination with state and private adult services agencies and providers that I'm going to be accessing, if you will, for the rest of my life. Now, transition planning, what's important at this point, particularly for young people, is there's a new law that actually went into effect July 1st. It's called the Workforce Innovation and Opportunity Act. It's referred to as WIO. And what's interesting about this is it literally mandates in a student's IEP, transitioning planning, be part of that packet starting at the age of 14, and then visited every year until the student leaves the school setting. And an essential component of the Act is establishing employability pathways first. It used to be a scenario, particularly with individuals that encompass the ID realm, that pathway to what was going to replace school when they graduated, more often than not, included a component of going to some type of day program setting. That's been turned upside down and inside out, and we really are seeing individuals themselves and families and now school settings really advocating that be secondary or not even on the table at all, that we really look at employability, employment first for individuals, and move forward in that planning, if you will. And something that's occurring right now that really is really kind of, it's taking off, and it's kind of exciting to see this, is a philosophical concept referred to as customized employment. And customized employment is a process, it's a journey of discovery where we really spend time figuring out individuals' talents, interests, and dreams, and then how can we realize those. And I've got to give you the caveat that this is not a quick journey. It's not an easy journey. Experience tells us that it's upwards of 300 hours to nail this down, where you're not only figuring out at a minimum 2 to 3 talents or interests of the individual, and then pairing that up with employers or business owners in the community where those dreams can be realized. It takes a lot of effort, and there's a great deal of literature that you can find that's very helpful. There's a lot of providers now that are becoming trained in this type of customized employment endeavor. So the resources are starting to be developed, and that's pretty exciting. At the very least, when we are talking about transition planning, what's important for the individual, for the family, is to develop some type of an employment toolkit that you can readily access and use. At a minimum, you need a resume with letters of recommendation. They really are the individual's calling card, if you will. In addition to that, with the idea that we are going to be become employed, then it's extremely important to have certain types of documentation readily available when those offers of employment come the individual's way. And these are, again, federal requirements. They call them I-9 information, having to do with immigration. Having copies of the birth certificate. You have to produce this. And give it to employers when they offer you a job. You have to have copies of your Social Security cards, these kinds of things. And I know in the case of the 4 of us being employed at the medical center, they don't issue checks anymore on payday. It's direct deposit. And so within the first 30 days of becoming employed at the medical center, you literally have to produce your bank deposit slip, if you will, to route those paychecks rather than getting 1 cent in the mail. We know we've sent a lot of information your way this afternoon. We've got a few minutes remaining. We are open for questions.
Thank you all so much. So for folks who have questions, if you want to send them our way using the questions pane, or if you want to unmute yourself and go ahead and ask over the phone, then we are open for questions for the next couple minutes. So if anybody has any questions. So the first question is whether or not the slides will be available. I can go ahead and answer that right now. I will send around a PDF of the slides with an evaluation form for CME credit after the webinar session. And let's see, we have a question from Anna. And the webinar will also be archived. I'll send a link to where you can watch the recording after the session as well. Do you have any other questions for any of our presenters?
Oh, Audrey, in case anybody is interested too, we didn't quite get to these slides, but there are a couple resources if people are interested on suicide prevention. There's a national hotline, bullying prevention center, and then general information about bullying and autism. So we'll put that in there, as well as some references. They'll be in the slides as well, but I want to put those out for people to have.
Great, thank you so much. And we do have a question from one of our attendees. It says, I love the idea of using behavioral markers to evaluate mental health, but how do you make that work in context where a person is subject to behavioral modification strategies?
What kind of markers are you referring to?
I haven't heard that term, behavioral markers. Is that...
It just says behavioral markers.
Is it talking about the depression equivalents? Yeah, I guess I've never heard that term, behavioral markers, before. So I'm not quite sure how we can answer.
Can she clarify, or he clarify?
She doesn't remember the exact term that you used, but
It's behavioral.
Behavioral equivalence is probably what we're thinking it means. So I think maybe the question is, if we're looking at behavioral equivalence, but they're in treatment, then that might muddy the water in terms of knowing what their baseline is, because their baseline would hopefully be changing if they're in treatment. So I guess in that situation, their baseline they would be improving from baseline. So if you saw a regression in those areas, then that would be more of an area of concern.
Yeah, and you would also their behavioral equivalence would change, so that would have to be updated as they made progress with their plan.
great. So do we have any other questions for our presenters? So it doesn't look like we have any other questions right now. If folks review the slides or the recording and have additional questions that they want to pose to any of our presenters, you can certainly send them along to me. My email will be on the correspondence that you receive after the webinar, and I can put anyone in touch with our presenters if you have additional questions.
Sounds great, Audrey. Thank you so much.
Thank you.
Yeah. Thank you all so much for a great presentation. Thanks everyone for attending.
Take care.